have requested that we look at single-payer healthcare and specifically the Washington Health Security Trust Bill that is under consideration for the 2015 legislative session. I am very proud that the board agreed to look at this and consider whether or not we want to voice as a district support or opposition for these efforts. I'm of the opinion in healthcare we really cannot be neutral on single-payer healthcare. You're either helping it happen or you're helping us stay in the current status quo. And I'm a big advocate of us moving towards a single-payer system. I think it's a better foundation for a healthcare system. It's not a magic solution, but it's a better foundation. Our speaker today is Dr. Ken Fabert, MD, practicing physician with Group Health, career-long advocate for single-payer, and a member of Physicians for a National Health Plan, amazing advocacy organization that helps educate and monitor the status of our healthcare system. So I'm just really appreciative of being here, and I'll turn it over.
So I've been told I've got about 10 minutes to cover some of this, so it's a tall order, but basically before I even start, I want to just say that I think it's safe to assume that everyone in this room basically agrees on what they want. And what everybody I know wants is good, affordable health care for their families, for their communities, and for their country. That much I think everyone can agree on. It goes without saying some of this has been made partisan, and it really shouldn't be. It's just a problem to be solved. And this is a solution that I think holds a lot of promise and covered broad brush strokes why. This is where we are.
Thank you very much.
Sir Winston is by no means a flaming left-winger. He's a lifelong Tory, but a brilliant.
Well, he did actually, he was a liberal
At one time, right. But this is a pretty good summary of where we've been. We've tried just about everything. And in 35 years of healthcare, I've seen a lot of it. And tested a lot of it. Crashed some of it. Yeah, so we need to do the right thing at this point. Anybody know what that is? Yes, I might. It's a terrible low resolution.
Yes, it's a marker to history on the hospital.
It's actually close. It's a fire mark. And in London and in some of the colonies, you would see these affixed to a building. And this is a little wordy. Bear with me. My wife and critics said this is way too wordy, but I'm going to show it anyway. Because it's a parable. It's about where we've been and it's about where we need to go. After the Great Fire in London in 1666, fire insurance companies proliferated, and when you paid for indemnification, they gave you a fire mark to affix to your building. They also were providers. They had fire brigades. They were specific for the insurance company. And if you didn't pay, or if you had the wrong company and the wrong brigade at your fire, the gold is mine. Guess what happened? They wouldn't show up, or they'd go home and let it burn because you hadn't paid. You with me so far? You kind of seeing the parallels here? And then the last bolded bit is pretty soon insurance companies ascertained that this was just not working, and so they petitioned the government to provide the fire brigades. Okay, you're all intelligent people. I'll let you extrapolate from there. So why single payer? These are very broad brushstrokes, but these are such big numbers that people say, no, that can't be. This is America. We're number one. We're exceptional. We do great things. We provide miracles. People come from all over the world to get health care, all of which is true. But we also waste over $400 billion a year. It's estimated by the Harvard School of Public Health that 55,000 excess deaths can be attributable to the lack of access to or coverage by insurance. 55,000 people. Okay, we've got 330 million, but 55. Do you think if 100 wide-body jets crashed every year, we do something about it? I think we would. Waste and fraud, universal coverage. It's this gets into the whole issue of healthcare as a human right. People debate that, but I think a lot of countries have moved ahead and embraced that with great benefit. So how do we know this isn't working? 50% of personal bankruptcies aren't a bad night at the casino. It's not credit card profligacy. It's getting sick. And and that includes underinsured. We've got the worst health statistics of the entire Organization for Economic Cooperation and Development. Our WHO ranking, right up there with Albania. 19% GDP now, it's going up. We don't collectively negotiate with the pharmaceutical industry like everybody else does. The new hepatitis treatment's gonna be $1,000 per pill per day for 3 months, do the math. It costs $1.50 to manufacture. But we don't call it capture. Understrain litigation, even after Obamacare is fully implemented, it's estimated there will be 31 million uninsured people. Doesn't quite take us there. This is from the Commonwealth Fund. If you're really interested in this stuff, they're a wealth of information. They've got they do great research. It's a nonpartisan data crunching organization, but they look at policy. And I'm familiar with New Zealand because I actually went there and decided to test drive single payer for a while. And the data speak for themselves. These are a little bit old now. New Zealand's probably up to 9.5% GDP. We're up to 19. But the expenditures are staggeringly different. Their outcomes are better. We're not number 1. We're number 7 out of 7. And for all that money.
7 out of 7.
Okay, so that's a segue. That's the case. I mean, I think the case is compelling. We need to do something. I will say, in all candor, I'm not a policy guy. I'm not a legislative guy. WHST is a work in process, and it's sort of like, Bismarck's sausage making and legislation. The sausage is still being made, and a lot of things have to be cracked out. But here are the broad brush strokes. Proposal is who's eligible? Everybody. Exceptions, currently people with federal beneficiaries of federal programs like CHAMPAS, like other things, and Native American programs with Bureau of Indian Affairs and so on. I guess my understanding is the plan is to negotiate with the feds to get waivers, to get those monies back into the WHST pool, to provide the services as an exemption, but there is a very lengthy process, legal process that we have to go through to do that. Okay, what is covered? Basically all health services, dental, prescriptions, through negotiated formulary. I'll segue, in New Zealand, every prescription costs $3. Now, you couldn't get a 3rd generation erectile dysfunction drug for $3, but you didn't need it. You couldn't get, a Me-Too antibiotic, but it was a very functional, streamlined formulary. And, okay, it's only 3.5 million people, but it's 3.5 million people versus Pfizer. Here it's you versus Pfizer. Guess who wins? Long-term care, diagnostics, and mental health. So basically, the full spectrum of single-payer services found in other countries. The funding. Washington employers are to pay an assessment of payroll, plus there'll be a flat rate premium for everybody over 18. Medicare and Medicaid beneficiaries is a little bit of a sliding scale worked in there. Alcohol taxes, cigarette taxes, tobacco settlement monies, federal funds after the waivers are obtained, and then co-pays. Again, I'm not a health economist. I can't crunch the numbers, but they can be made to work. It's also proposed to include funding for L&I and community health centers. Okay, payment for providers and facilities. The important thing to emphasize here is that providers are independent. They're entrepreneurial. In fact, my experience in New Zealand was there were far more independent entrepreneurs practicing medicine in New Zealand than there are here, where people practitioners are increasingly forced, particularly primary care, to become part of a group or become part of a larger consortium like Group Health or whatever, simply because they can't survive as individuals. A lot of people, once there's a guaranteed income stream, the primary care people can be pretty nimble to respond to demographic changes, community changes as they grow. They can hang on a shingle and actually survive. So it was actually more entrepreneurial, not less. As far as the hospitals and care facilities, again, it's It's a negotiated global budget. My understanding is that that will be facility by facility. So I would think that Jefferson County is in a pretty good position to be on the vanguard, and as a critical access hospital, provide a pretty good argument for some services that are important and actually become a leader. So additionally, no restrictions on which provider or group anyone can see. So there's actually more freedom, not less. Your insurance companies are telling you which preferred provider you can see, where you can go. No restrictions on employers providing additional insurance, but the goal of WHST is to make it streamlined and inexpensive enough that they wouldn't need to or want to, really. And finally, no restriction on Medicare recipients using WHST as a secondary. So this is straight out of the Healthcare for All Washington summary sheet, which I thought was a good summary about basically is what insurance is about. I mean, isn't insurance just to have a large pool, and in the unfortunate and unlikely event that something bad happens to a given individual, the pool absorbs the shock of assuming this. Unfortunately, cherry picking, exclusions, pre-existing conditions, etc., rescissions, diagnostic redlining, dumping, I've seen it all. And, you know, it's not in anyone's interest, and it really causes problems for individuals who are subjected to this kind of insurance industry stuff. And obviously we don't want to walk away from a fire for lack of a fire mark. So what is it? Sorry for a stray bullet there. Anyway, it's simple, it's fair, it's accountable, it's affordable, it's universal, it's smart. Okay, yeah, we need some primary care on the teeth, and toothpaste and toothbrush is the way to do it. But this is how we do it in this country. It's crazy. It's really pretty simple. So, and this was in Vancouver at the Winter Olympics. Yeah, yeah. So anyway, that's just a real big thumbnail. I don't know if there's room for questions. I can hang out afterwards.
So there is, excuse me, there is time for public comment right now. Yes. So Jennifer Taylor, you wish to make a comment?
One of the things that always gets me when people argue about how good our system is that we had so much more illness, chronic illness of several different kinds, and yet we pay twice as much as our peers. We're not dumb. How does that happen? How can we pay so much and still have worse health? It's just something we've got to work on. I think it's partly social, partly medical, the way our medical system is structured. But I think it's something we can do something about. I think we should.
Thank you, Jennifer. Dr. Holloway.
Hi, I'm Catherine Ottaway. I'm a family practice doc in town for 14 years, and I'm one of the mad as hell docs who went across the country and talked about single payer. When I went across the country, people would say to me, I don't want to pay for the obese smoking couch potato. I don't want to pay for his health care. But the thing is, we are paying for it, because what happens is he loses his job, he loses his health care, he gets depressed, he starts drinking, he's smoking, he has a heart attack. And what do? He comes in here, he gets life flighted over to Seattle, and they put a stent in, and guess who pays for it? All of us. We have the most inefficient, expensive healthcare system on the planet. And I think it's stupid. We all agree, everybody deserves health care in this country. You are all allowed to go to the emergency room and get care. But you know what? That is the worst way to deliver care, because you can't take care of chronic illness. So why don't we get it together and get a good system? We need single payer. Thank you.
Thank you. Linda Sutton.
Okay, I didn't really prepare remarks, but I did spend a great deal of time when I was in California. The last year I was there, about 4 years ago, doing healthcare, single payer healthcare forums during the whole summer of Obamacare. And I worked with the Physicians for National Healthcare. They were there with us on that and presented wonderful background and showed everybody how far down the list the United States really is in terms of the delivery of health care, because it's all dependent on money. It's dependent on corporations. Corporations have a stranglehold on our medical business, and it is a business. Until we remove the business from healthcare and make it into a right, we are going to continue down this same terrible road. Now, one of the problems that I saw when I did all this study, and I read far more than I remember now, but there are many different forms of single-payer healthcare, and that's what most people in our country never had a chance to even evaluate because they took it off the table. So there's a different system in Canada, there's a different system in England, and there's a different system in almost every one of the countries has a different variation. But the whole idea is that they weren't really studied. Now we have Vermont stepping up to the plate. Oh yay! You know, Vermont actually did it. Gavin Newsom did it in San Francisco, which is a county. You know, San Francisco City is a county also. And you know, so we were really hoping that it would be in California. Sheila Kuehl, who was the author of the single-payer bill, was just elected as a county supervisor down there. We're really hopeful that she's going to be able to help get Los Angeles County moved forward. And I really thank Matt for bringing this up and for, I mean, how many people vote for a politician and he gets in office and he actually does what he said he'd do? I mean, really, like, yay.
Thank you, Linda. Patrick Noonan?
Hi, I'm an old guy and I've got to have some notes, I apologize. We built our healthcare system around employer-based insurance, and it's done well. It pays hospitals a lot better than Medicare pays them, and that's what's changing hospital behavior now. And hospitals, and I'm talking about big hospitals, have responded by buying up little hospitals. It gives them more leverage against insurers and employers. They're seeking more profitable procedures instead of harming the others. They're buying up doctors' practices. They're building all kinds of offices and facilities. They're hiring very expensive middle managers, service line managers, etc. They're hiring lots of people in the business office, coding, upcoding, chasing claims, and they have to play that game to survive. That just widened the gap further between Medicare and between employer-based insurance. Now the employers are starting to bail on us, and that's terrifying. It's unsustainable. So hospitals, we hear all the time, we need a better payer mix, we need higher reimbursement, and that's not likely to happen. When the employers bail, people wind up on a bronze plan or some kind of catastrophic plan and essentially pay for their own health care anyway at pretty high prices. Single payer solves all of those trends, keeps the employers in the game. They don't know it yet, but it does. It reduces their costs. And if you want to know, is this a follow the money thing? Somebody alluded to that. Here's where it's going. Large healthcare systems are the #1 offender now. That's terrible. The insurance industry, the pharmaceutical industry, the device implant industry, where I came from. Specialists and surgeons, many of them making north of $1 million a year now. Lobbyists, and a distant seventh are the malpractice attorneys that you may have thought were 2 or 3 on the offender list. They're way down that list. Our lobby, the American Hospital Association, supports single payer publicly. Privately, almost all of the members oppose it. Maybe next year. That's not completely that is kind of the way our Congress deals with deficits. Jefferson Healthcare's goals, if we look at the webpage, aren't really aligned with the district's needs, but they're good goals, but they just don't mention cost. That's our biggest problem today. Our district's businesses and families are kind of the victim of high costs now, and our single payer bill is self-funding. If you don't hear anything else from me today, it's self-funding, and it deals with cost. Healthcare costs now for a family, I just read yesterday from the AMA, healthcare costs for a family now exceeds the minimum wage nationally. It's like $16,000, what, $8 an hour. Folks, it's time to quit moving this ball down the road and stand up and be accountable. So much.
Thank you very much. Deborah Peterson?
I'm here to present to you the resolution passed by the Jefferson County Democrats last night. When we heard about this meeting, it was one of the reasons we scheduled a special meeting last night. And I will read you the now therefore statement. We give a lot of reasons related to the kinds of things we've been hearing resolved that we, the Jefferson County Democrats, urge the Jefferson Healthcare Board of Commissioners to support and our legislative delegation to become co-sponsors of the Washington Health Security Trust bills to be introduced in the 2015 legislative session. And I think that in this community there's a great deal of support for single payer, and the Democrats are trying to channel that to you, and I know that this hospital organization is very responsive to its public, so we're delighted that you're considering this. We hope you'll find it something you can do.
Thank you very much, David Jenkins?
I've worked in healthcare for 50-plus years as a clinical microbiologist, either in this hospital or in research facilities in California. And I have several friends who are nurses, physicians, and they have told me they need to get out of this business because it's moving too much towards the corporate pattern. And that corporate pattern means non-physicians, non-medical people are making healthcare decisions for you and me. And one of the ways I think we could get insurance, quote, corporate insurance, and I think they're the big driving force behind this, is to go to single payer health and get the corporations out of healthcare.
Yay.
And get it back into the hands of healthcare people, because their concern is health, not money.
Thanks very much, David. And then David Berrien? Pronounced it correctly. Thank you.
I just wanted to note that there's a difference between private hospitals and public hospitals. Private hospitals have board of directors and they make decisions based on their private interests. Public hospitals have leaders like you that, and your role as advocates for public interest. And I think this is especially important in this discussion here, because for each one of you, I'm hoping that you're really taking in what is in our public interest and take a real leadership and advocacy role in promoting that interest, not just here, but throughout the entire community. I would like, just as an aside, to note that because you're a public hospital, and this is one of the things that is different, is that this meeting is an open public meeting, and of course it is, and I appreciate the opportunity to come here. Second problem with being a public entity, having a public open meeting, is that you're required to accommodate people with disabilities, and that would include people like myself with a hearing disability, and unfortunately I've not found that to be the case here.
R. Sidney Collins?
Yes, what I want to say is, well, a number of things. For one, a strong nation, no, I don't want to start this way. Most of the nations in this world in history that have fallen first because of internal decay. If you want a strong Washington and a strong America, we need a healthy, strong people. So we have a healthy, functional culture. Count von Bismarck knew that back in the 1800s in Germany, because he knew that a healthy German people meant a strong Germany. We don't always like what they did. So I think that's really important. Single payer is an answer to that. 2, employee pay. That was something unions had to do at one time, long before General Motors was admitting this. I was saying General Motors, for instance, at that time they were the largest corporation in the world, needed publicly financed health care, so they wouldn't have to pay so much overtime and they could hire more people. And they could compete with foreign nations. That's a handicap with our industries. So that's another reason we need that. Third, the results. I heard something like about 10th or 7th. What I understand when it comes to longevity and expected lifespan, and they are two different things. Infant and fetal mortality, go down the list. We are at the bottom. We're somewhere around 40th of the developed countries in the world. Those figures keep varying because it's flexible. The other thing, oh yes, Obamacare, the Adult Affordable Care Act. It helps some people. But do you know why they delayed it till 2014? So that they get geared up for the rest of the people that were going to be forced into the system, either on their own means or on the public dime, for more and more profit. United Healthcare, Aetna, et al., and others. That's going to be our main obstacle, because I think the people want it. They're in the business of not paying out. That's what an insurance company is. They invest the money, they're not spending, they're a bank. They're in high finance. And we've been opposed tooth and nail by these people down through the generation. There are trillions of dollars, the last I heard, in profits when you look at them collectively. They're not on our side. So for employers, for real business, people that make things for our country, we need single payer. It just makes sense. We pay, what, half of the healthcare costs in the world, and look where we are in the standing. Thank you.
Gretchen Brewer.
Hi. I really appreciate this presentation and that you're taking up the issue. I guess I'll keep just a couple comments. One is about the bankruptcies. I personally know of three families that have had to sell their houses because of, for health care, to take care of health care. And these are three families that had really good health care, health insurance. But yet they had catastrophic things happen and they had to sell their houses. The sadness that goes with that. And by the way, they weren't, the person that brought up the Democrats, these people were Republicans, all three of the families. I hadn't thought of that until she mentioned it, but all three of the families were Republicans, so it affects people across the political spectrum. Let's see, the other thing is about, I know through my life, I've known lots and lots of people who have had to keep jobs that they didn't necessarily like or want in order to keep health care. So their whole career was stagnated because of that. And I think especially in a community like ours, where we have lots of people trying different things with their lives and I think single payer healthcare would help us have a more vibrant economy because people would feel more free to go out and try things and get businesses up and running. And they wouldn't have to worry about, can I afford to take care of my health if I go out and try this new adventure? So I'll leave my points to that. So thank you very much.
Thank you very much, Gretchen. Nobody else is on the list to make a comment. So Mr. Flynn, do you want to comment?
Well,
I just came.
Yeah, I'm sorry. My name's Marcia Prince. Sophia Prince, and I was just at home reading the newspaper, so I saw this meeting was happening. And I'm just really passionate that there be single payer health care. I think it's, for myself in my life, the financial burdens of trying to come up with health care have been an enormous source of stress for myself. And in fact, I've had 2 TIA episodes in the past month. And it's all stress related, but part of the stress is due to the health care that's available and the unevenness of what's available, not knowing from one year to the next what's available. For example, with Obamacare, in some ways there's things that are really helpful about it, and actually due to that I was able to be taken care of here at this hospital. I had wonderful care. I've never really thought too much about the hospital one way or the other. I mostly do alternative care, but boy, I was really glad I was here. It helped me tremendously. I had great care. But so as you go into this next year, like say you're at the income level, I've tracked a lot of stuff because I did a lot of thought about it last year. And like if you're the lowest level of the people who get the subsidies, for example, like say I think it's like last year, say a silver plan and the subsidies, because I'm not even counting the one that you don't have a deductible, you don't pay a deductible, because then you're out, what, $5,000 or $10,000 for a family. Boom, if you don't have that, you might as well have no health care. So now they have raised the premiums for people who are on the lowest rung. So what was I think 86 or $76 a month, I think it was $76 a month. Now, that plan is $184 a month. And I'm trying to figure out how does this work, because I think the premiums that in the open market only went up maybe $40, so they've added that $40 on, and then they've taken away subsidies. So a person is now paying $110 a month more at that same level a year later after starting it. So what are they supposed to do? They're earning $23,000, $23,223 a year, and all of a sudden they've been smacked with $110 more a month to pay. Are they going to be able to stay on their plan? I don't think so. But what are they going to do? So it's like, that's stressful to people, you know? I mean, so if people knew they had health care, I think they would flourish more instead of kind of always on the edge. And you'd say, well, why can't people do better? Because these are stressful times, and there aren't so many jobs. You can't just turn around and get that more money that easily. So anything that would reorganize it so it would take that sort of uncertainty out of people's life would be a tremendous help. So I urge you to vote for it in favor of it.
Thank you very much. Thank you. And so, I'm going to have to draw this public comment to a close, and there will be public comment afterwards, but if you, last one, Julie, Jane?
Yes, tomorrow. I remember when Obama had his White House enclave, and there was not one representative from single payer allowed into that final big deal. But Congress received, I don't recall the percentages, but it was a huge percentage of voters from across the United States called them, and 70 or more % were carrying on about needing single payer, wanting this system. It was such a big deal that Nancy Pelosi got up and said, what did she say?
Off the table.
It's single payers off the table. Don't even, just stop right there. That was so offensive to me that Congress would not even take it up. That I think we're laggards even now. We're in the 21st century, and we're now just getting a grip on the common sense of this. So if for no other reason, this should come up on the table, and it should get a lot of oxygen and a lot of input. And I hope you play your role in that. Thank you.
Thank you very much. So now I will turn to Mr. Glenn for a comment on that.
Sure. First, I want to thank Dr. Fabert for taking the time to come and present to the board tonight. Thank all of you for attending this evening's meeting as well. The Jefferson Healthcare is very involved in advocacy, both at the federal and the state level. We engage with our congressional delegation annually, and we engage with our legislative delegation annually as well. We put together a advocacy agenda, and then for the last at least 4 years go to Olympia and meet with Representatives Van Duyck, Behringer, and Senator Hargrove face to face and say, here are the things that are important to us. Because there are a lot of things that go on in Olympia that have profound impact on Jefferson Healthcare and our ability to continue to meet the needs of the community. This presentation, its timing is great because we're right in the middle of putting that advocacy agenda together, and I think I speak for the board in thanking all of you for attending tonight, and this will help us make a more informed decision as we shape that agenda. So thanks.
Yes, so I also would like to thank our presenter today, and of course I was involved. I grew up in a single payer system. I worked in a single payer system, and so it's very good to hear another perspective about someone who's worked in that single payer system. We do have a full agenda today, so we will now take first of all, thank you for coming, and we appreciate all your input. And I was last evening at the Democratic meeting and had an opportunity to say a few words there. But we will take a short recess because it's a fairly long, full agenda today, and we will resume district business at 4:15. We will take a 5-minute recess. Anybody who wants to leave and doesn't want to stay till the end, we look to probably be going until about 5:30 or so before there's the next public comment session. So if anybody would like to leave,